We'll get interrupted by that little Zoom voice. Again, everyone, welcome to August 25th Zero Suicide Learning Collaborative. Today, we will be hearing from representatives from CAMS. CAMS is the Collaborative Assessment and Management of Suicidality. We'll be hearing from Dr. Crowley today, who's a senior consultant with CAMS. I'm going to go ahead and stop sharing my screen. Again, please feel free to keep checking in the chat. And if you have any questions coming up during this presentation or after, please feel free to drop those in there as well. Thanks so much. And I'll toss it over to the folks from CAMS.
Conlon, thanks so much. Thank you for the invitation to do this. This is really, really exciting. Good morning, everybody. So as Conlon mentioned, my name is Kevin Crowley, and I'm a consultant with CAMS Care. What that means basically is I'm a clinical psychologist who primarily does clinical work, right? That's most of my day-to-day is clinical service delivery and supervision and things like that. With CAMS, I get the chance to do a few things. So I do some training, some calls, and some product development, which is why many of you may have suffered through my acting if you watch that 3-hour video course that DPHE is very generously providing. And just kind of setting the stage for today, I thought this was an amazing idea when Lena and Conlon threw it out there. But essentially what they had suggested was this would be a nice time to take like 45 minutes, maybe 50 minutes to just talk through a few things, right? Talk through, for some people who may be more familiar, just a quick refresh. And for people less familiar, just a quick overview of what CAMS is and where do you see it in the context of a zero suicide approach. But then, a little bit more of the time, if we figure that's about 20-ish minutes or so, more of the time just kind of open for a couple of other things. What is DPHE providing in terms of training? What do we see going on there? For people who hop on consultation calls, what can you expect? And then just a much broader, more open Q&A for anything that people may want to ask about CAMS in your particular population, or what could this look like, or really anything. How does it compare to other screeners? Is it a screener? Hopefully you'll know the answer to that by the time we get there. How does it compare to other interventions? All that kind of stuff. So, please feel free to toss questions in the chat in the first few minutes if we want to make sure to not lose anything. And then we'll just open it. We'll make it much more informal once we get to about 10:30 or so. Just very quickly, if you'll indulge me hopping back and forth between two different things here, I'll show you a couple of slides, and then I'll show you a couple of things that I really like about our forms, just by way of overview here. So I recognize that some people on the line here may have already, or may have already done one of these trainings, or may actually be really well versed in CAMS from the work that you've done. So I don't want to sell this as like here's the introduction. I was thinking about framing it in some ways as sort of like what are the most common questions that you get when you do these trainings? What are some of the things that come up? And use that as a way to sort of straddle the fence of review and information overview. One of the questions that I get most frequently, I feel like it's like clockwork, I can expect this, is how does CAMS compare to the Columbia? We know that CAMS gets touted around as a bunch of different things. It gets thrown around as an intervention, but also gets thrown around as an assessment. And assessment is a very heavy piece of this. So how does this compare to a Columbia or the PHQ-9 or something like this? And my answer is pretty traditionally, it's kind of like comparing a hammer and a screwdriver. They're both really, really useful tools. But the kind of tool that you want to choose probably has a lot to do with the kind of job you're looking to do. And they do very different jobs. Because CAMS is not a screener, right? Screeners have a really important purpose in our healthcare setting, in zero suicide, right? Screening is a key thing. Can we gauge and can we get a sense of where is risk? Is there risk? Is there something going on? The rough equivalent of if a paramedic shows up on the side of the road, we want to do maybe a quick body scan to see, are you feeling pain anywhere? Is something up? Something that requires a little bit more attention and a little bit more focus to fully diagnose, but we know to tread lightly. That's what screeners are, right? Is there something up? In the last 2 weeks, have you had thoughts about death or dying? Or, in the Columbia screener in the last 3 months? Many of us probably have had thoughts about death or dying in the last 3 months, but that may or may not be suicide related. It just lets us point a spotlight on something that we get to investigate together, and we get to investigate further. And one of the reasons why it's so important to investigate further, I think, is Some just very brief data I want to share with you, because this is another thing that comes up in trainings a lot. Why don't we just hospitalize the second somebody says they're thinking about suicide? I think the reality is it's a multifaceted answer. We could talk about hospital care and what happens in there and how therapeutic can it really be. But I think for right now, bridging off of the assessment question, another big piece of this is there isn't just one suicide presentation. Suicide isn't a one and done thing where the presence of thoughts means the definitive presence of behaviors. And I think this data is really interesting for showing this. 2020 data, most recent data that we have available, about, let's just talk adults for a minute. 12.2 million adults had serious suicidal thoughts. A very small percentage of them made a formal plan. An even smaller percentage chose to act on suicide, and an even smaller percentage of that completed suicide. There's about 45,000 and change. I think it was like 45,600 adults died by suicide in 2020. Out of 12.2 million people who had ideation. So why does this matter? Are we trying to downplay the fact that it's only 45,000 people? No, of course not. Or that it's only 1.2 million who made a suicide attempt? It's kind of a staggering number when we think about it. It's just really interesting to reflect on this because the reality is the vast majority of people for whom suicide is on the table as an option may not be close to choosing suicide as the option for managing it. I don't want to assume that you're not as a clinician, but I also don't want to assume that you are before we can get in the weeds together. That's the whole purpose of assessment is where are you on this? How close are you to choosing this option? Are you somebody who's had thoughts, who's had fantasies, who thinks it would be better to just not wake up in the morning? Are you somebody who's making plans? Are you somebody who has access? Where are you at here? And it's a trend that we find consistently throughout the lifespan, right? We're looking at this breakdown for adults, very similar breakdown for adolescents. Significantly more people have serious thoughts about suicide than choose the option. And I use that term very literally, right? And very purposefully, the idea of choose the option of suicide, because one of the foundational components of CAMS is the idea of suicide is an option. It's an option any one of us or any one of our clients could choose at any point. Some people are closer than others to choosing it. But regardless of where you happen to fall on that spectrum that we were just talking about, there is one thing that every flavor here has in common, which is the presence of pain. Because suicide is an option. And it's an option that makes sense in the context of pain that I feel trapped in, that I feel I can't live with, that I feel I can't cope with. So the idea of CAMS as an approach, as an assessment, is to kind of go past screening, right? So we know something is on the table. I want to see what it is. I specifically want to see what is the pain that makes suicide make sense, that we know is there, regardless of where you are in that 12.2 million. If you're on one side or if you're closer to the 45,000, doesn't matter. Where does your pain? And how separately and safely are you managing it? That's what it sort of all comes down to. And this is the heart of what CAM speaks to when we talk about this idea of drivers. What's driving suicide for someone, directly and indirectly? And these are terms, again, you may be very familiar with from CAM's training, but just by way of a overview / refresher, there's a lot of stuff that makes life very painful. Here's some examples on the slide here, and they're examples that I imagine the clinicians on the line can think of a lot of cases that they're working with right now, where you're checking more than one of these boxes. PTSD is profoundly painful, right? So would be the fact that I have to deploy again, or that I just lost my job, or I'm living paycheck to paycheck, and I have to skip a couple toys for my kid's birthday because I don't know how we're going to make it to otherwise. That is really, really painful. Any one of these things could be in the mix for suicide being an option. But the real art of it, and I think what CAMS is trying to get at, starting in that first deeper dive assessment, is what's up for you? What's going on for you specifically? What is it about whatever that puts suicide on the table as an option that we feel we need, or as an option that we're at least seriously entertaining? What is it about any one of these things that takes you from the average everyday pain going on to pain that I feel I need suicide to solve? And I'll give you a very quick example of this. I'll give you like a really fairly benign example. We could talk more if people want to about drivers and about some more complicated ones. But in the interest of time, I'll give you my very first one. This is my first CAMS case I ever did. It was when I was in a university counseling center. And perhaps not surprising anybody, I had a freshman come in right around finals time of the fall semester. So right around December. She comes in very sheepishly. Like, I think that I should be here. My roommates were really concerned. They weren't really sure if I was okay, because I was kind of saying that I don't know if I can live like this. I don't know how I can keep doing this. And I said, okay, what's going on? She takes this big breath in. So I start getting very tense, like, what's coming? What's coming? I have 3 finals in a 24-hour period. And I sat there, and I think I probably involuntarily was like, come on, there's got to be more with that buildup and with everything. There's got to be more, because on the surface, right, that doesn't sound like anything. Tons of people have 3 finals in a 24-hour period. I did. I had one of the worst caffeine withdrawal headaches I've ever had in my life, but I wasn't suicidal. But you're telling me that is linked to, I think I want to kill myself. So the idea in CAMS is, if you are telling me this is tied to your pain, I believe you. You're the expert on your pain. But I need a little bit more, because that right there is kind of indirect. It doesn't answer the question for me of what's up for you. I need you to show a little bit more work. This is where, when I do my trainings and stuff, I talk a lot about how I almost go full 8th grade math teacher sometimes. I need you to show the steps, right? 3x plus 5 equals 15, minus 15, minus 15. How do you get to suicide step by step? What's the narrative here for you? And this is the narrative that she spelled out. Kind of streamlined. She goes, I am really, really ugly. And I am really awkward. I don't make friends easily. I've never had a boyfriend. I really would love to have a family. In my generation, I don't know how old she thought I was. In my generation, if you're successful enough, none of that other stuff matters. And she goes, look at Mark Zuckerberg. So again, I'm sure Mark Zuckerberg's listening. I promise this is a quote, right? She goes, he is freaking weird. He is one of the ugliest people I have ever seen. But that dude found love because he changed the game. I know exactly what I need to do to change the game. I know exactly what grad school I need to get in to make that happen. I know exactly how much I need to study to get the grades I needed to get there. And I can't put in that effort correctly if I have 3 finals in a 24-hour period, which means I'll never get to the school I need to be successful enough for someone to love me. Ding, ding, ding. This is it. This is what we're trying to get to. This is what we're kind of talking about in the pursuit of CAMS is, what's going on for you? Yeah, 3 finals in a 24-hour period sucks. Of course, depression sucks. Of course, PTSD symptoms suck. But not everybody who checks these boxes is trapped in a way that suicide becomes a higher and higher option. So what is it for you? And when we answer that question, there's a little bit of a light bulb moment that follows, right? Just this idea of, oh, I get it, which is what Dave Jobs talks about all the time. If you've seen these trainings or watched the videos and stuff, with empathize with the suicide wish. I'm not necessarily condoning it, even though I am saying suicide is an option. But I'm saying I can see exactly how you get to that option in the context of the pain that you're feeling trapped in. And the more that we're able to land on that stuff, the better treatment follows. Because you start, when you get into the treatment piece, you start being able to do 2 different things. And this is where I think CAMS as an intervention is really interesting. Because CAMS as an intervention is trying to box the stuff that we can do into one of two boxes, I would say. This is one person's take. But I think suicide-focused interventions pretty broadly could be categorized as A, what can we do and how can we empower you to not choose this option when you are really close? If you're on the edge looking over, how do we help you put your hands up and take a step back? What do we do to help you ride out that crisis? So this is where we get into everything from environmental interventions, making the environment safe, making lethal means harder to access or removing them entirely, putting up positive reminders of reasons for living. Like if I'm worried about overdosing, but I'm staying alive for my kids, putting a picture of my kids on the medicine cabinet, on the medicine bottle, in the medicine bottle. So making the environment safe, safety planning, cognitive challenging, increasing connection, decreasing isolation, DBT strategies and skills that help us survive the crisis in the midst of that distress tolerance, regulate emotions. Tip skills are incredible for this. But what do we do to help you? Hands up, step back. That's one. But we also have, what if we could kind of not just have you step back, but turn around and choose to walk in the other direction? You're moving away in the same way, but it's a very different process, right? What would it take to help you choose to live with pain or to move with pain, move through pain? What would it take to help you move in the direction of a life that's worth living? That's where we really start getting into drivers focused interventions. So to kind of flesh this out just a little more, I'll play this case through. When our client here said that about, I'll never be successful enough for someone to love me, the first thing I did was hop into problem solving, right? I was definitely a little less polished, right? I got to solve the problem. You need an intervention every session. And what blurted out of my mouth pretty quickly was, have you talked to your professors and asked if you can move your exams? And she goes, you can do that? I was like, yeah, you can do that. She goes, all right, I'll do it today. I said, great, let's follow up tomorrow. We set another session for the next day. It was like a Thursday into a Friday. She comes in the next day, she's skipping. She goes, I'm all better. I go, what happened? She goes, I emailed all three of the professors. All three of them got back to me. The first one said, no, absolutely not. Under no circumstances can you move this test. Okay. The second one did something that I thought was kind of cool. I hadn't heard of before, which is I'll give you a 48-hour window, 24 hours before, 24 hours after, right? So if the test was Wednesday at 2, anytime between Tuesday at 2, Thursday at 1:59, you take the test. That was kind of cool. The third person, who to this day I'm convinced was another graduate student, was essentially like, I don't care. Like, the grades are due on the 20th. Can you please get it in before? Otherwise, I'm not sure what I'll do. So she goes, it all worked out. I'm all better. She is not all better. There's a lot more work that we want to do, especially on the pain front. But I think what's really cool about suicide-focused intervention things is that we can move between the two, and I think want skills and interventions for both boxes. It's really helpful in the moment on the crisis management side of things to have the deepest possible box for what can we help you do to move back? What skills can we offer? How do we help you tolerate emotions? How do we help you challenge thoughts? How do we help effectively safety plan? Can we remove some of the stress by targeting external factors like reaching out to a professor? Again, can we make the environment safe? But if that's all we do, what do we have next time? Or what do we have the next time I still walk away feeling like I got to work at least as hard as Mark Zuckerberg in order to earn love? So this is, I think, in a nutshell, what really defines CAMS as a treatment. And I think another frequently asked question that comes up for me a lot when I do these trainings is, how many sessions of this thing do I got to do? What does that look like? How does that go? it's 12 sessions, right? Like we got to go through a full 12 sessions of care. And the answer is sort of like a yes asterisk, in the sense of we do recommend 12 sessions of care. But when I'm working with clinicians, many of whom are steeped in evidence-based approaches and who are working in settings that really support the delivery of evidence-based practice, 12 sessions of an evidence-based practice has a very clear connotation, right? It feels very much like the CBT protocols, which are awesome, but very manualized and intentionally so, right? Where session 1 has this content that needs to be followed up by the content of session 2, session 3, session 4. And it does feel like if I don't give you 12 sessions, I'm not giving you the full treatment, right? Which is not always true in practice. We can be very flexible with some of these things in practice as we sort of take the evidence and deliver it with our clients. But it does feel like if this is the package, 12 sessions, I got to deliver it in this way for 12 sessions. I think what makes CAMS very different is it's not the same kind of package. Because CAMS isn't a therapy that tells you what you have to bring in the room. It's a therapy that allows us to really dive into pain as much as possible and in a way that facilitates this pretty powerful connection so that we see it from the same angle, we understand it from the same angle, and then we get to figure out where to go from there. It's essentially like a way to make sure that your compass bearing is calibrated. So I know where I'm going. But then you get to choose the destination, right? So like right now, as an example, we could talk more. I don't mean to only harp on one. I just feel like with one case, you can hit all these things. If I said, here's your case right now, this person is alive, made it through finals, and we want to work on this pain, there's tons of different ways you could do this, right? We can do some cognitive focus challenging. We could do some behavioral exposure. We could do some ACT, something that feels more third wave-ish, meaning, I don't know if it's necessarily a third wave, but it is a very different thing of challenge and make go away versus accept and let stuff go, right? We can do some insight-focused work. We can do some attachment-focused work. We could consider support groups. We can do all these things. And what CAMS would say on that is, you did it. Good job. Effective treatment isn't necessarily defined by what you choose to bring in the room. It's defined by, are you choosing to bring something in the room collaboratively that gets at this pain? If it is, you did good CAMS therapy. Which I think is really interesting for a lot of people, because I think for a lot of people, particularly the newer clinicians I get to work with who are either or both newer to CAMS or newer to clinical work, it can feel a little bit tricky to wade into this waters because there is a lot of comfort and there is a lot of certainty that follows. Here's the manual, and if I do this right, then I'm doing a good job. It's a lot scarier to think there isn't an objective right. But what's kind of cool when people sort of let themselves do that exposure is it's a lot more freeing too, because you know that you're right. Because you know you're walking in the right direction, and any steps you're taking in this direction, assuming they're collaborative and assuming they're pain focused, are going to facilitate a different relationship for this person. I think what's kind of cool about that too is that it leads to some flexibility that has allowed CAMS to be incorporated into a few different kinds of settings, which is a question we get a lot too, is can you do CAMS for mobile crisis? Can you do CAMS ER? Can you do CAMS in an inpatient unit? The answer is yeah. Because it's not that you have to deliver 12 sessions in order to get everything out. It's starting from session 1, we're walking a journey towards understanding and clarifying your drivers. Even in just one session, if I have one session with somebody where I go through that SSF and we're able to sort of synthesize information in such a way as to say, here are the problems suicide's trying to solve, or at least our best approximation of them after one session. Here's why I think this referral is going to make sense for you in your pain, in the context of it. That's a heck of a service. If I got 2 sessions where I can double down on that and explain it in a little more detail and even start sort of fleshing out, Here's some of maybe the box one interventions you may want to consider that would be helpful to learn for stabilization, hands up, walk back. Here's some of the stuff that I think would be really helpful for your pain. That's really incredible. And frankly, something that people aren't always getting when they leave a locked unit. Much more commonly, the experience people are getting is a shiny new prescription, regardless of how effectively the old one was working, and a hefty bill. The more I get to work with you, the more we get to chip away at your drivers. And if I get to work with you outpatient for a long time, we start hitting a groove where this is exactly the kind of treatment I would be doing with you anyway. This is exactly what I would want to work on with you. It's just we're bookending our sessions with some assessment and some treatment plan update. I'd be going after this pain the way that I would normally because of what occurs to me and us together. But just fleshing this out so you see where it goes. The reality is, I think that there are some interventions and some approaches that kind of land better on some programs than others, right? So like, for example, safety planning, means restriction counseling, CAMS are kind of used throughout right now in terms of settings that are using them. DBT, the cognitive therapy protocols, like cognitive therapy for suicidal patients, which is the CTSP there, and BCBT, most commonly used outpatient. Doesn't mean you won't see inpatient units where they're using DBT skills or groups where they have DBT skills groups, or that there aren't really kind of incredible inpatient adaptations like PACT. PACT is this adaptation that Marjan Holloway out by me here in the Maryland area has been developing for a few years. And it's sort of a more focused, brief, kind of like cognitive therapy protocol for suicide specifically for inpatient units. It's awesome. It's very cool. But it needed to be tweaked because the reality of inpatient unit, you can't be doing 12 sessions. And the reality of inpatient units is that you don't have the bandwidth typically to do everything that we know is effective in DBT care. But I think that flexibility in CAMS is something that allows it to be adapted and used in these different settings in such a way that, not to oversell it, I'm not a salesperson, right? Not to oversell it, but I think is a good reason why I appreciate everybody on the line here, at least learning about CAMS or seeing if it's a toolkit that would fit in. Because I think at the end of the day, kind of my final thing here, and then I'd like to hit into questions is, at the end of the day, I think what's really cool about the things that are, all right, two thoughts. What I love about zero suicide initiatives like this, and why I was so excited to be a part of this, is that I think they're kind of effective no matter what. Lena and Conlon and Diamond put on great content just from what they were telling me about previous things before. So I think they're effective. But even if they weren't as good as what Colorado is putting out there, I think it's effective to just be talking and be habituating to suicide. Even if you came on and just listened to somebody drone on about stats for an hour, I think that's really effective because it allows us to feel more comfortable with the topic and feel more comfortable wading into pain and wading into conversations around where are you in this mix. But I think what's also cool about it is that the more that we're sort of investigating similarities and differences between, let's say, I'm going to say less the assessment side, because there's pretty clear differences between the suicide status form and the Columbia, but more on the intervention side. I think we're starting to see that there's some really amazing potential differences between the hammers and screwdrivers of like BCBT and CAMS and DBT. And I think the more familiar that we are, and the more on top of the nuance of what these things offer, the more empowered we feel and comfortable we feel playing around with the what to use with whom when questions. So with that, I would love to back off and open up the conversation. Well, actually, I guess maybe I'll do one other thing because I remembered looking at the group here that this was another question Conlon had flagged. Just kind of very briefly saying, what are the trainings that we have and what are things that are available just right now? So Colorado DPHE has very generously been providing a bunch of trainings for a few years in the context of a grant that we have going on that we have another year on together. And in the course of doing so, many of you may have done some or all of these things, right? Watching the video with Dave and me, doing a day-long role play training, and attending some consultation calls. Right now, Colorado clinicians can access these calls in a couple of different ways. There's sort of a main one and then one that we're playing around with. We have calls once a week that are being delivered that you can access a coupon code on and just hop on and talk questions, cases, hear from other providers. We've also been wondering about, and I think this could be a cool idea, having some Colorado specific calls, particularly in the next month or so for National Suicide Prevention Month as like a first experiment. But then the idea would be on these calls, we can do whatever. We can talk cases, we can talk systemic implementation questions, we can talk challenges, we can get into some interesting niche things like rural service delivery, which I think are really, really cool. I'm happy to give more information about that, but I also would love to just open up for any questions of any kind about CAMS, application, anything people would find helpful here.
Thanks so much, Kevin. I know we had a couple questions come in from the survey that was sent out beforehand, but I want to hold some space in case there are any questions live. And for this more discussion-y portion, if you feel comfortable turning on your camera to chat with the folks we have from CAMS, that would be awesome. But yeah, thank you so much. Please feel free to drop questions in the chat or come off mute, and I can go through the ones that were submitted beforehand too. Getting some praise in the chat, Kevin. Hearing that the CAMS consultation calls are going well at Jefferson Center, as well as Centennial. Another question was, do you do in-service training from small teams?
You know, we do. That's a great question. We do in a couple of different ways. There are trainings that we've offered for smaller groups. I think I'm going to be doing one for a group of 6, which is the smallest that I've ever done before in in a few weeks or so. What tends to happen, and I think what I would actually really encourage would be there are some times where groups come up and reach out to us and they can talk with someone like me or my colleague Mariam about, here's some service and training options that are available. I tend to point people to the video as a good way of getting your feet wet, just seeing what it looks like, seeing if I want to invest in this more, and then hopping on a role play training. What's awesome about the fact that you're connected with Colorado is that we have that available just through the grant and the services they're generously providing. So what some groups have chosen to do, some groups have said, okay, let's connect, let's connect with Diamond or Conlon or Lena about getting access to this video, hopping on a role play training, and then maybe doing some of the calls that are going on right now, like that we have.
We start recording. Again, these slides, oh shoot, it's not letting me share now. Here we go. We have plenty of resources at your disposal. The National Zero Suicide folks just released this toolkit and survey to contribute any of your questions or ideas into developing new resources that they can offer to other systems. I believe that's open through this Friday, so please do check that out. And then once I send out the slides for this meeting, please do feel free to click through these other links and webinars and training opportunities. I believe all the ones that are listed here are free to register for, and a second page, including those links from CAMS. Again, I'll be including CAMS information after the Learning Collaborative is posted online. So if you have further questions, please feel free to reach out to them or OSP with any specific things you'd like to discuss. But otherwise, I will look forward to seeing folks at the next Learning Collaborative on Thursday, September 22nd. And thanks again to the reps from CAMS. Really enjoyed your session today. Appreciate you being here.
It was a pleasure. Thanks, Conlon, Lena, Diamond. Thank you, everybody, for organizing this.
Thank you so much.